just if I could get a sense of the room, how many folks here don't know much or haven't heard much about SCOAP, the Surgical Care Outcome Assessment Program? Okay, so what I'm going to do is give a primer on what SCOAP is about. And Izzy, to address your question about the impact of antibiotics, in the state of Washington, we're schizophrenic. Half of us do, half of us don't. And none of us do it for a consistent, reliable reason. So the confounding is just unbelievable. Although we'll say that we only use it in the patient who needs it, who is at risk, you're doing it in ACDFs and microdiscectomies. How can that, the behavior is really unusual. But it's a large cohort. There's about 10,000 in each of those groups. So as we track these patients, and our tracking is 70+% at 2 years and 80+% at 1 year, we're going to be able to answer that question. There'll be sufficient N number to do that. One's going to be the right way to go. So for those who don't know what SCOAP is, it's a clinician-led, physician-led quality improvement initiative that focuses on cost effectiveness, safety, and quality. The source of the data is the medical record. So this is not CHARS billing data. This is medical record data that's abstracted. The platform is sufficiently facile that you can use it in a variety of subspecialties and still have the kind of granular data that you're seeking. The physicians who work are the ones who set up the metrics, the definitions, so they help empower the tool to be very accurate. We benchmark behavior and we benchmark hospitals. So the hospitals are benchmarked, say if you want to take a look at skip measures and what's your normothermia rate. If you want to look at diabetes management, how well do you control blood sugars? How well do you even measure blood sugars? All of those things are part of the tools that we use, and then we reflect that back 4 times a year to our hospitals, our payers, our patients, to show improvement or lack thereof. The folks who run SCOAP, the advisory board, are physicians and stakeholders. The stakeholders that we think of are the 5 Ps: the patient, the physician, the payer, the policymaker, and the product or device manufacturer, which you can also substitute the 5th P for pharma. And they participate in looking at the metrics and advising on where to set strategy and how to move forward. With our research group, the data that comes out of SCOAP goes through the Certain Hub, and Danielle Lavallee is going to show you some of the impactful and incredibly powerful analytics that they're able to deliver. The research group takes a look at the data that comes out of SCOAP, makes recommendations to the metrics committee about what the next level metrics should be to answer the questions that the data raises. The physicians who are on the metrics committee design the new metrics, and it gets inserted into the tool, and we harvest that data across all the hospitals. The funding, who pays for it, therefore who owns it, is the hospitals. And then it's supported through the research group work done by the Certain Hub out of Dave Flum's shop at the University of Washington. The benchmarking process, in order to be a benchmark hospital, you have to participate in at least 10% of the care. So benchmarking hospital, so you can't be a small boutique hospital that just does left big toe toenails, and that's all you do. And you do it beautifully, but you don't do anything else. Our hospitals have to take care of all of the folks in the state. And so you have to reach a minimum. The top 25% is established by those hospitals that have the highest benchmarked outcome for any particular topic. And then we roll that every quarter so that you can watch your hospital continue to improve or not, and then you can engage your administration and your nursing to get that improving. So when you look at the growth, we're now at about 24,000 cases. At the end of the year, we're at 20,000. It's the standard distribution of lumbar and cervical that we all see in our practices, and we're biased toward fusion because that's the controversial topic. We are growing outside the state of Washington, and our colleagues in the University of California system are the most recent to join us. When you look at what the registry does, it looks at patient behavior factors. It looks at characteristics of care. Patient behavior characteristics are like smoking or opioid use, and that is the variability of smoking. As you can see, about 1 out of 5 patients goes in for a fusion operation and they are still smoking. Some of us believe that you should not be operating on people who smoke, and other colleagues don't believe that way. And we don't insist one way or another, but we just record. And as you can see from a public policy perspective, SCOAP has had a significant impact on the smoking rate in our state. Same with opioid use. It's an epidemic, and embedded in that toxic variability slide that you see there are populations who will never get better from your surgery, and it's important to be able to identify them. And with this metric, there are 20,000 patients, so half of them, there are 10,000 folks with opioid use. They're going to the operating room for spine surgery, and we're going to be able to, with secondary metrics, analyze that group and find out what are the characteristics of risk, and then keep those patients out of the operating room and treat their problem. As you can see from the blue line, the longer you're in SCOAP, the better things become. Here you're seeing the opioid use rate drop. We do cohort studies. We separate the cohort studies because the characteristics of these hospitals behave differently in each of the cohorts, and it's important to know that. This is a hospital metric. You're looking at blood sugar measurement. You're seeing there's scattering all over the place, so it's not consistently done. You'd think that every person who's a diabetic would get a blood sugar. But that's not the case. There are some hospitals that do it less than half the time, and that is improving over time. And this is a really important thing for a surgeon. The rate of insulin use for hyperglycemia in our hospitals is not consistent. So there are many hospitals where you are hyperglycemic through the surgical procedure and you are not given insulin. And as a surgeon, you know that's going to increase your risk threefold. And you would not prefer that to happen. And that's the same number, the 200, that Paul was referencing earlier in his talk. If you stay in SCOAP longer, you improve, and that problem gradually improves, but it is an ongoing management problem. Same with postoperative occurrences. These decline over time, and this is a huge savings. What's important to realize is that the average cost of this is about 50 grand, and if it's a surgical site infection in an instrumented spine fusion, that's 100 grand. And if you have a 15% rate and you do 6,000 cases or more per year, that's 900 multiplied by 100 grand each, you're sitting at $9 million. If you can drop that rate in half, that's huge savings in suffering, and it's huge savings in cost. And that applies to all the adverse events, whether it's inadvertent ICU admission, myocardial infarction, new neurologic deficit. All of these are tracked and benchmarked. And this is your adverse events slide, again showing the longer you're in it, the more it goes down, and the serious adverse events rate is around 2% for our long-standing hospitals. This is a really important tool for physicians. This tool allows you to participate with patients in shared decision-making. It's based on the database. It's predictive of outcomes. It's predictive of pain. It's predictive of function. It has the patient characteristics, the diagnosis characteristics, the surgical procedure characteristics, and the baseline scores built into it. And Danielle will be showing you this tool I use every day in my office. I just have people plug their stuff in, and patients love it. It's a very easy tool to use. This is an important social slide. This is about the impact in populations who participate in SCOAP. These are hospitals who participate in SCOAP. They are the orange line. Hospitals that do not participate in SCOAP, this is their charge data. And what we see is there's about a $73 million savings for hospitals in our state based on 2013, which is the most recent charge data that we have available, compared to SCOAP hospitals. So participating in SCOAP not only improves patient outcomes, decreases your complication rate, it's very important socially for all of the patients in your state to have these kinds of quality improvement initiatives ongoing. And we encourage all of our hospitals to join, but that sometimes is a challenging discussion.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.